Okay. So I'm Livia. Tom sort of explained basically what Andy and I have been doing this month. We set up the labs, we both did a project, and then we have an internship. And the difference between these internships and maybe you guys have heard of the Pre-Med Academy is that the Pre-Med Academy shadows physicians, and we have been shadowing NPs, so nurse practitioners, and PAs, physician assistants. And I got the opportunity to shadow both an NP and a PA. The NP was in the surgery department at Maine General, and the PA was in the emergency department. So that's Jessica Richardson. She's a family nurse practitioner, which means that not only is she a nurse practitioner, but her training specialized in family practices. So she's able to treat infants and children, which most nurse practitioners don't get specialized training in. I spent most of my weeks shadowing her, but my normal day sort of changed from day to day. It always started with a morning department. So the entire general surgery department meets at 7 a.m. every morning, and they talk through all their patients, figuring out which people can be discharged, what their surgeries are for the day, what needs to be done, so that everybody's on the same page because they really work as a team, not as individual surgeons. And then after morning meeting, I basically got to decide what I was going to do with my day, which was nice. That's basically the nice part about shadowing the nurse practitioner and not a physician, is that because she does so many different things, I could also go off and do my own thing. So I look at the OR schedule, and if there was an interesting operation going on, I'd go check that out. And if not, I'd go do rounds with them, which basically just means that the pre-call surgeon, which is the surgeon that would be on call that night, goes around with all the PAs and the nurse practitioners, goes into every patient's room, figures out what needs to be done that day so that all of the nurse practitioners and PAs on the floor know what they need to do. Then my specific nurse practitioner, she's also specialized in wound care. So she does all the wound care patients, so I'd go around and help her with that. So there'd be different procedures depending on what the wound was. So if it was a wound that was growing, there would often be a biopsy where they take a piece of the wound, send it off to pathology, and figure out what's going on. Otherwise, it would be vacuum changes. So some wounds, if they're really bad, will have a negative pressure vacuum on it to facilitate healing, and those need to be changed pretty frequently. And bandages obviously need to be changed as well. So her responsibilities involve patient care, so that is mostly post-op patients that are still in the hospital. They go around, make sure that the patients know what their plan is, how long they'll be staying, and what their status is, and communicating with the nurses so that the nurses on the floor know what each patient needs in terms of medication, care, and anything else. She also does wound care, as I explained. She's also working on a really cool new procedure, normally skin grafts, which is like removing skin from one part of the body and putting it on a wound, so to help the wound heal. Those normally involve removing at least the epidermis and part of the dermis, but she's working on a new procedure that involves this machine that can remove only the epidermis and put that onto the skin graft. So that involves a lot less healing for the patient, and the wound that they make to take skin off heals a lot faster. She's also, the nurse practitioners sometimes have to act as patient advocates. So some elderly patients don't have family that are here to advocate for them, and they don't really know what's going on. You know, surgeons will come in and tell them, I think you should do this, or a physician won't have a lot of time to explain everything, and the elderly patients just say, yeah, of course, sounds good, but they don't really know what they want. And so the nurse practitioners have a little bit more time to go in, talk to the patient, figure out what their plan of action really is, and whether or not they actually want all the invasive procedures that they're getting, because some elderly patients just decide, I'm hurting and I don't want all these procedures anymore. They also often get called into the OR to assist procedures, so if surgeons are in the OR and need a second pair of hands to hold retractors or help out with suturing, they'll get called in there. So they always wear their scrubs at all times of the day to make sure that they can get in there as quickly as possible. I already talked about rounds, and then clinic usually happens in the afternoon, so that's post-op and pre-op clinic patients. They'll come in. Post-op patients, like you check their wounds, you make sure that all the sutures are okay, nothing's infected, and pre-op patients are making sure that they're ready for surgery, Some surgeons won't operate if there's even just a small cut on a patient, but definitely patients with infections can't have operations. So they need to make sure that the patient is ready and they know what procedures that they need to do before coming in for surgery. Basically, all in all, the job of a nurse practitioner is to make the lives of the surgeons as easy as possible, whether that be communicating with nurses or communicating with other departments. So a lot of patients need more than one department to be working on them at the same time. So the general surgery department might be working on something in the abdomen or taking out a tumor, but then there's also internal medicine or hospitalist or somebody else that is working alongside the general surgery department. So the departments have to communicate with each other to make sure that everyone's on the same page in terms of the care of the patient. And that's often the job of the nurse practitioners to figure out and to let the other departments know. So the biggest difference between a nurse practitioner and a PA that I was told about is that nurse practitioners have the ability to sign patients and treat patients by themselves. At Maine General, that isn't the case because they have their own rule that everybody needs to have a physician sign off. But in terms of the state of Maine, nurse practitioners can actually open their own practices if they wanted to. So what I got to do, I went to the morning meetings, as I explained. I got to watch a lot of surgeries and visit patients during rounds. And I also got to watch a lot of CCU procedures. So the critical care unit, patients get moved down there when something happens that makes the physicians think that they need a higher level of care. So on the floor, if they're in their room, usually it's one nurse will be taking care of 5 or 6 patients, but the CCU has a specific nurse for each patient, so it's one-to-one care. And that's often if the patient's on breathing machines, if they need frequent doses of a medication, like hourly doses, they'll be in the CCU because the floor nurses can't handle that type of medicine regimen. And the CCU patients are usually the ones that have the most severe problems, so there's often procedures going on down there. Interesting. I also got to watch with clinic, help out with wound care, and I even got to scrub in on a couple plastic surgeries, which was really cool. So I found that shadowing a nurse practitioner gave me a much broader understanding of the whole system than my past shadowing experiences that were with physicians, because you not only see the very top of the food chain, I guess you'd call it, where the physicians are the top tier, but the nurse practitioners are involved not only with the physicians but with the nurses, and they have a much broader perspective of the whole system. The second shadowing experience that I had was with an emergency department PA, and so that's the guy that I shadowed. He's been there forever, really knows his way around. So a normal day in the emergency department basically just consists of visiting patient after patient and trying to get through as many patients as possible and getting as fast a turnover as you can get. So when patients come in, the PAs will go in and assess the patients, first ruling out any life-threatening possibilities. So they have the ABCs, which are airway, breathing, and circulation. And once they've cleared those, they would order any necessary tests depending on what the patient is complaining of. So that can be blood work, scans, and also psych consults, which often happens because the emergency department is about 50% psych, where there'll be different patients like schizophrenic patients, suicidal patients, bipolar patients that come in, and they often need to call crisis to make sure that the patient isn't dangerous to themselves or to anybody else. So the thing that's unique to the ER is that all these tests are ordered simultaneously because they're trying, like I said, they try to get as fast a turnover as possible. So the ER is a really expensive visit just because all these tests are expensive and all of the tests are ordered at the same time. So a lot of tests that people would order only after a different test comes back negative get ordered simultaneously just to expedite the process. So the other thing that he'll do is communicate with other departments that he might need to consult with. So even when I was in general surgery, we'd often get called down to the emergency department in order to consult on a patient that might need to be admitted to our department. And then finally, he makes a decision on whether or not to admit the patient or send them home or give them further recommendations as to what they need to do. So I found that shadowing in the ER gave me exposure to a really wide range of patients, and it really showed me a bigger sample of the Maine population, because I find that here at Colby we really don't get to have that much contact with the population of Maine, and this really showed me how many different types of people live here. So we had patients of all ages, from infants all the way up to people in their 90s, and all types of complaints. So there were things like someone had his ring stuck on his finger and we needed to cut off his ring, all the way up to patients that were about to die. So we had a lot of patients come in with withdrawal. So that could be withdrawal from alcohol or really hard drugs. And oftentimes those patients would come in, especially the alcohol patients. Alcohol withdrawal is actually extremely severe and can lead to death if not treated properly. So they'd come in extreme pain, wanting any help that we could give them, and say, I want to be clear of alcohol. I want to go up to the unit and be helped with my withdrawal, and I want to detox. And then once they settle down, they say, oh, actually, I think I'm going to go home tonight, but I'll come back tomorrow first thing and go get detoxed. And they'd have to sign out against medical advice and get told that if you don't go home and drink right now, you're probably going to go into a coma and die, because your body craves the alcohol, and we can't give you the necessary medications to help you safely detox. And these patients would sign out and say, I'm coming back first thing tomorrow, and 99 times out of 100, they wouldn't come back. We had a lot of young mothers come in, like mothers at 14 with babies that had problems. So we had to deal with that, where the relationship with the mother and then the mother's mother to the child is very different, because the mother's so young that they're still in school, that often it's actually the grandmother that's acting as the mother, but that comes with its own complications, because the mother still feels like they're the mother of the child. We had a couple incarcerated patients, so that comes with its own issues, because they come in with the police come in, and the police are in the room, they're handcuffed to the bed, and you have to ask them if they're taking any drugs in prison, which they're not going to tell you in front of the guards. And so you have to ask the guards to go out of the room, and it's a much bigger procedure when there's patients that can't tell you things when other people are present. We had a lot of traumas come in, so people that had car accidents or heart attacks, and that comes with its own issues, because a lot of people that come in after a car accident don't want to get admitted to Maine General in Augusta and would prefer to go to Portland, because Portland's a bigger hospital, and that comes with its own complications, because they might be in critical need of a surgery, but they won't want to do it at Augusta. And Portland has all sorts of hospitals send things to Portland, because it's a bigger facility. And if they can't get in at Portland, they'll wait instead of getting the surgery that they need at Augusta, and might die because they decided that they didn't want to have surgery at Maine General. We had physicians and family members of physicians come in, which is another complicated issue, because they feel like they have knowledge about medicine, obviously, and then you have to treat the patients differently when their parents are physicians, because the parents have their own opinions on what they need, and often you don't feel that that's what it is, but you still need to respect that and make sure that you're catering not only to the patient, but the physicians who love the patient as well. So that was my shadowing experience, which was really interesting, and I highly recommend it. Like Tom said, the other thing that we did was a project. So my project involved this skull, which I'm sure you've all heard a little bit about, but just to briefly go over the story. The skull was found in the football lockers in 1984, and that was the year that the frats were disbanded at Colby. And so in the 19th century, dissecting cadavers was seen as a ghoulish act, and so the supply of cadavers was very low because people weren't willing to donate their bodies to science. But after Darwin, the demand for cadavers skyrocketed because everyone was trying to gather as much information as they could. So there was a lot of different ways to supply that demand, and that involved people or their families signing the rights to their bodies to science to donate it. They could be purchased from authorities, so people who had unclaimed bodies or people that died in jail were often purchased and then used for science. But then there were also less ethical methods to get those bodies, which involved grave robbing or even killing people that came from a poor background. So this skull in particular is interesting because its nasal bones are bent to the side, which you can see here on the front of the skull. So that likely suggests that the person had a broken nose, and that often leads people to become mouth breathers because they can't properly get air through their nose, which could, whoa, what did I do?
Let's go into
There we go. So that often, becoming a mouth breather often leads to a loss of teeth because you're getting all this bacteria in through your mouth. And that you can also see in the mouth that a lot of the teeth are lost. And the big underbite can often be caused due to that loss of teeth because there's nothing stopping the jaw from coming forward. And being a mouth breather can also lead to a lot of sinus infections. The very interesting thing about this skull is the sutural bone that is seen right here on the back of the skull at the junction of the lambdoid suture and the sagittal suture. And that is very common in Peruvian people of Incan descent, which are people that come from a poor background. So it is possible that this was one of those people that were killed for their bodies. We don't know. But that raises a lot of questions in terms of how the skull got here, whether or not it even belonged to Colby before it turned up in the football lockers. But if it did belong to Colby, how Colby came to be in possession of the skull and what the ethical implications of that are. So my project involved getting a CT of the skull. So I went into the radiology department at Maine General, and they helped me get a CT. So I'm going to show you a couple of the things that I found. So this here is an axial view, so we're coming down from the top of the skull through it. Here you can see the really big sinuses of the skull that come almost into the orbits. So there's barely any, let me see if I can find a better one. This one, there's only a very small line that comes in between in between the sinuses and the orbits. And here you can see the nasal bones have been eroded quite a bit. And if you see on this one, which is a 3D reconstruction of it, you can see the large underbite from above. But basically what the radiologist helped me with was getting different views of the skull. So this is a coronal view from front to back, and this is a sagittal view from the side. And with all of these scans, he was able to create some 3D images of the skull that can help us see some more things inside the skull here and learn a little bit more about what's inside of it. And he also gave me this one is a very thin slices of the skull so that you can use, one of you maybe, if you end up becoming Tom's TA and want to take on a project like this can be used to create slices of a 3D image so that you can scan through the skull. So there's a lot of different implications, obviously, that we can use with these 3D images, but it was a really interesting experience for me. And yeah, that was my JanPlan. Any questions?
Do you know anything about the springs? Would those go in an anatomy classroom?
Usually when they're if it's a skull that's used in a lab, there'll be springs, which is why we assume that before it wound up in the football lockers, it at some point was used in a lab.
So skulls that are used for as anatomical specimens, you want to secure mandible to the skull, because if the skull has it's articulated, and the skull is set on a flat surface the way it is without the mandible, so if you take your hand, you go into the crease of your neck, and you go right in there, you'll feel a little ring right there. It's called the highway muscle. There's a bunch of strap muscles attached to that muscle. I joked in the class about it keeps us from, keeps the neck up in there, and that muscle on the superior end attaches to a bone called the styloid process, spicual bone. And if you stick a skull and then without snap that off, so I don't actually is, but it used to be when the skull. Ensure that didn't put spring. Another indicator that it was in fact she showed you there, 3D one, but pull the go to the top of the skull. Rotate it forward. Yeah, there you can see it. And so it's been trepped. So wow.
Yeah. I think I want to go into pediatrics, but I think I want to become a physician. I'm right now. The track is med school, but who knows? Yeah. Over the summer, I did an internship at a hospital in Austria, in the general surgery department. And what's really interesting there is because it's direct entry medicine, the students in my age have already started medical school, so I was able to scrub in on a lot of procedures and actually help out a lot in the surgery. So, yeah. Mm, ooh, that's a tough question. Um, I guess I got a lot of patient contact that you don't always get when you shadow physicians because they're sort of in and out. They just see the patient briefly before surgery and then after really quickly. And with the NP, I really got to spend quite a bit of time with the patients and see the implications of the procedures that were done.